Good evening, everyone. I am Phyllis Ellis, president of the Brockton area branch NAACP. I am here tonight with our partners, AdMeTech Foundation with Dr. Faina Stern and Good Samaritan Hospital with Lynn Cornelius, and we welcome you to our event this evening. We have been hosting these events for over 7.5 years now, and we are still going strong. Our goal is to inform men, mostly African-American men, about the risks of prostate cancer and to get them to be in charge of their health. When we first started our program over 7.5 years ago, Brockton had the highest rate of mortality among Black African men. I want to say, give kudos to Steve Bernard for bringing our attention to this program. He's the one who initiated it 7.5 years ago. So thank you, Steve. Prostate cancer does discriminate. And like I said, Black men are 2.5 times more likely to die. This evening, we will hear from distinguished doctors in different fields of medicine who will discuss the current status of metrics of the COVID-19 pandemic in Brockton, the advances in screening and diagnostics of prostate cancer, the clinical perspective on the advances in prostate cancer treatment, and we will hear the description of our newly formed prostate cancer equity program. Tonight's co-host is Steve Bernard. Steve is a past president of the Brockton area NACP, and he's also the coordinator of this newly formed prostate cancer equity program. Steve, like I said before, Steve initiated the program 7.5 years ago, and we are still going strong. So Steve, I welcome you and take the floor now.
Thank you very much, Phyllis. I'd like to thank everyone for participating this evening. I would be remiss in not giving Phyllis Ellis, the president of the Brockton area branch of the NAACP, all the kudos for the fine work that she has done, increasing the membership of the Brockton area branch, bringing civil rights, equal rights, and community activity to Brockton at a level that we have never seen in the Brockton branch. So we are blessed to have you as our president, and we look forward to many more years. Thank you very much for hosting with me this evening, and thank you everyone for joining us this evening. Albeit the work that we have done over the last 7.5 years, the crisis still exists. Men at high risk of prostate cancer, Black men of African and Hispanic descent, men age 40 and over, and men that have a history of prostate cancer in their family are still at high risk. And it behooves us to be vigilant, to continue to put these education and awareness forums on for the community. We believe that we are saving lives, but we cannot do it alone. We need everyone's help. And we have the help of some very, very important people in our state legislature. The Brockton delegation of state legislators, including Senator Michael Brady, will be here this evening to make a few comments. Mike Brady will make the first comments. From what I understand, Jerry Cassidy will be with us at a little bit later in the program, and Senator Walter Timilty will also be with us. At this time, I would like Senator Michael Brady to address the group. Mike Brady is the senator for the 2nd Plymouth in Bristol County District. Michael, are you ready?
Yes, thank you, Stephen. And thank you, as you mentioned, kudos to Phyllis Ellis with all her work with the NAACP and bringing awareness and membership. And kudos to you, Steve, as a former leader of the NAACP and a great friend. And thank you to all the people on the line tonight on Zoom. I know everyone's time is valuable. I thank you for taking me first because I do have 2 other commitments tonight. But Dr. Stern and all of us, we were meeting for the past several years to bring awareness to prostate cancer and the testing and all of that. And it's been more prevalent in the ethnic minority communities in Brockton and the surrounding towns. And the biggest thing we talked about is getting the word out and educating people. In my own family, my father had prostate cancer, and luckily he was a veteran of World War II. He was able to go to the VA in West Roxbury and had a procedure done. But it's a thing that in the past, a lot of men didn't want to talk about. It was kind of embarrassing, whatever. And it's so important. And even today, we're hearing constantly with the more information we have that testing and the procedure is so important, preventive medicine. And I have to get tested for not only that, and I know earlier colon cancer was mentioned. My mother had colon cancer and she had to have a colostomy and all that, and I got to get tested for that. But it's so important educating our constituent and friends, and we've had friends on the line in past meetings that thank God for their testing and getting things done properly, that they're still alive, that they're with us today, if not for the work that everybody has done. And Dr. Stern, who's been a tremendous advocate leading the charge, she met with us at the State House. She's come in and educated other legislators in the State House, so we were able to get important funding for this to address it and get the word out in testing and in procedures and so forth. So any help we can do moving forward. I'm grateful to Mike Rodericks as well. I'm on the Ways and Means Committee in the State Senate, and Mike Rodericks has been a big advocate. He represents a community in Fall River and Westport and the South Shore, but Fall River, similar to Brockton area, is a city, and it was in an old industrial city, and he's been aware of this, and he's listened to all of us when we advocated to get the funding, and he's supported this. So it helps at the local level, but we can't get it done without the rest of the delegation working together. I know our Brockton delegation, Jerry Cassidy, and I know Claire Cronin was involved before she became the ambassador. And I know Walter Timbley, who represents some similar communities that I represent, will be on later. He's a good friend and senator, but and we are going to have a new representation in the city of Brockton too. So we hope to get whoever wins that rep seat to get educated and brought up to speed. And I'm always willing to help and open my doors to educate any new legislators coming on board, because we have a group in Brockton that works very well together, and thank God for that. No one does it alone, but everyone on the front line, everyone here on this Zoom meeting tonight, you are the experts. You have been there. You've educated us to help us to do a better job in the State House. And the important thing is again, as I mentioned, not only the funding, which we've been able to get it in the budget, but also getting the word out. And that comes through with funding too, but utilizing that to educate our public, because as I mentioned, and I don't mean to be repetitive, but it was a thing that guys didn't want to talk about. And I've seen it in my own family. I know many on this line have seen it in their own families, and preventive medicine saves lives. So moving forward, I'm going to be here for about another half hour before I have to get to 2 other meetings, but please keep in contact. Anything I missed tonight, I know Steve or Phyllis or anybody can call me later and get me brought up to speed of anything I missed tonight. But moving forward, we do have an economic development bill that's coming out that will bring more money to the communities, but we already passed the prostate funding in the budget, giving funding to AdMeTech and other entities. But next year, to get prepared for next year's budget as well, is so important in educating the public. And I know earlier it was brought up about COVID as well. We hopefully have gone through the worst of the times. I lost a brother in Avon who was 8 years older than myself. He got diagnosed with COVID 3 years ago, and it affected his circulation, and he died. And we've lost too many families and friends. And Brockton was the second highest hit with COVID numbers in the Commonwealth outside of Boston. Thank goodness for all our healthcare workers and facilities and all of us working together. I've been on these meetings on Zoom with the local hospitals, the VA, the Neighborhood Health Center, and Sue Josh, and again, our county officials, because if not for getting that money into the Plymouth County, we get it distributed faster. So we set up a thing at the Shaw Center for testing and vaccines, where some of the communities outside of Brockton, it was back and forth day and night whether they were ever going to get the testing of the vaccines. And I am worried because, as I mentioned earlier before we started this, that because of the weather, we're going back inside. We're not going to be out in the fresh air as much. There is a concern of numbers going up, and that's a big concern again with COVID, that we got to keep trying to educate the public to get, whether it be proper testing or vaccinated to save lives. So I'm going to be listening. I'm here more. It's more important. That's why we have 2 ears to listen and keep my mouth quiet. But thank you for all you do, and any help we can be moving forward. You know, my door is always open. So thank you again to everybody online.
Thank you very much, Senator Michael Brady. Next, we have the mayor of the city of Brockton,
I
Brockton
apologize, Steve.
Sullivan, is he present yet?
Steve, I
I'm here,
apologize.
Steve.
I apologize, Mayor. I think we have Senator Timothy here.
If I may, and thank you very much, Doctor. If I may, Steve, I'm more than happy to defer to the Mayor of Brockton. He's a great person, and I'm more than happy to follow him.
Well, Walter and I went to Boston College together, and he is a senator. With all due respect, I'm going to let Senator Walter Timothy, who's a great public servant, speak following Senator Mike Brady. So, Senator, the floor is yours. And Walter, I appreciate everything you do and working with Mike.
Well, thank you very much. It's great to work for the Brockton delegation. Thank you, Steve. Thank you, Phyllis, Dr. Shuren. Thank you so much. I am proud to be a member of the Greater Brockton delegation. Senator Brady is the dean of the delegation, and Mike's looking more and more like the dean every day. So, Mike, thank you for your leadership. In all seriousness, and this is an incredibly serious topic, I thank you very much to my friend Deb Roberts, Select Board Chair in Stoughton, for inviting me to participate tonight in what is a tremendous public health priority and a central issue in men's health. I have for years, along with my colleagues, strongly encouraged advancement of early diagnosis and, of course, treatment. On a personal note, my father is a survivor of prostate cancer, and thank God he benefited from early detection. We need early detection for every single member of our society, every single member, and it's incumbent upon all of us to make that case to the public and make awareness even more prevalent. Our doctors, our nurses, our public health professionals do wonderful work. We need to partner up even more so with our public health professionals, like Dr. Shuren from AdMeTech, to make sure that the word is out that we need early diagnosis and early detection. Access to accurate diagnostic tools for early detection and treatment obviously is the best way to battle this disease. And that, again, is incumbent upon us, ourselves as public officials, to make sure that the resources are there to go hand in hand with awareness and the absolute very best when it comes to our medical professionals, which we already have, but also our equipment and our institutions, to make sure that each and every citizen is a beneficiary of wonderful medical care and takes advantage of early diagnosis and early detection. It's very important that we are here tonight, gatherings such as these, and I thank the Brockton NAACP for all the wonderful work you do in so many ways that elevate us all as a community. The notion to continue to raise public awareness is crucial. Education is crucial. And we, through education and public awareness, will increase awareness of prostate cancer and the need for early testing throughout a Commonwealth in our nation. Furthermore, we must address healthcare disparities and the needs of our fellow citizens who are most vulnerable to this disease. That is crucial. That is crucial, and that is part and parcel with early detection. We are very fortunate to be residents of the Commonwealth of Massachusetts for so many reasons. The Commonwealth of Massachusetts leads the way in so many issues that are near and dear to our heart, whether it be medical treatment, medical care, our medical institutions, and of course, social justice. So tonight, I thank you to Deb Roberts for inviting me. I thank the Brockton NAACP for being leaders in so many different ways for all of us and elevating us all as fellow Americans. With that, I look forward to participating tonight with my colleagues in government, Senator Brady, Chair Deb Roberts, Mayor Sullivan, and Rep. Cassidy, and working with each and every one of you and for you to encourage early detection and to eradicate this insidious disease amongst us all. Thank you so much.
Thank you very much, Senator Timothy.
Thank you.
Next, as you already heard, we'll hear from our Mayor, Robert Sullivan of Brockton. Mayor Sullivan has been an ardent supporter of our programs since his time at the City Council as chair of the City Council, and as mayor, he has presented at these forums many times in the past, and his contribution is always very valuable. Mayor, we welcome you. It's always good to see you.
Steve, thank you. Thank you very, very much. And I would be remiss if we didn't take a moment of silence for former State Representative Geraldine Creedon. Jerry Creedon passed away. I saw Steve at the funeral and Mike. And again, she was a city councilwoman, and she was a true supporter of not just Brockton, but the Commonwealth. If we could just take a moment of respect for the Creedon family. May she rest in peace. I want to thank President Ellis and all the members of the Brockton area branch of the NAACP. And I specifically want to thank Mr. Bernard. Steve came to me a few years back when I was the council president and brought education in my life, because I did not know that men of color 2.5 times more likely to come down with prostate cancer. Just didn't know that. And as a son of a cancer survivor, my dad had prostate cancer. Every day I'm so thankful for the dedicated doctors that specialize in this deadly disease. Dr. Zolls is an angel in my family for saving my dad's life. But I also want to thank Dr. Stern and AdMeTech Foundation. Really, I can look around on the screen on the Zoom. It's the new technology Zoom, and I see lifesavers that have helped us here in the city of Brockton and beyond during COVID. One thing that I would humbly ask is that any man listening, get tested, get your blood test, get your PSA. I just got mine several weeks ago. It's so accurate. Please do it. And if you're 40 or older, get that embarrassing exam, the physical exam. It might be embarrassing for a few seconds, but you can save your life. That's a fact. So I want to just, I truly want to just thank the doctors and all the clinicians. Without the help of the NAACP, we would not be able to get this information out. And as mayor, I would like to thank Dr. Rick Herman, a medical doctor who's our medical consultant for the city, who's been just an unbelievable advocate during the pandemic. And I'm also going to say how happy I am that the state partners and DPH has allowed us to hire through the Board of Health 3 epidemiologists for the next 2 years. So I'm going to humbly suggest that the Board of Health here in the city of Brockton will work hand in hand, partner with the NAACP and any medical clinician to educate and inform, not just about prostate cancer, although that's the genesis of tonight, but breast cancer and anything, colon cancer, as Senator Brady said. We have 3 really stellar professionals that are EPIs that are working with Dr. Herman and Dr. Monis here. So again, to be an effective leader, you have to be a good listener. I am just so excited that the medical clinicians take time out of their busy schedules. They don't have to do this, but I'm so thankful that they do. And again, thank you, President Ellis and your team. Together, we are better. So let's continue to educate and inform and save lives in the city of Brockton and the Commonwealth, and quite honestly, in the nation. God bless you all, and thank you for having me on tonight again.
Thank you very much, Mayor. Next, we'll hear from Dr. Richard Herman, who's the medical consultant to the mayor's office. Tonight's program is called Prostate Cancer Awareness in the Times of COVID-19 Pandemic. And Dr. Herman has been very, very helpful in giving us a dashboard and outlining how well successful the Brockton administration is fighting this deadly disease. Dr. Herman.
Well, thank you. And thank you very much, Phyllis, for inviting me again. I appreciate it. I'm not going to thank Mayor Sullivan because he's the one that's responsible for preventing my retirement. So other than that, off we go. And let me share some of the data. I know that we're here to talk about prostate health. And unfortunately, COVID probably prevented a lot of men from getting prostate health while we were all locked down. But let's go over the numbers and what we're looking at in the city. We used to focus a great deal on case counts and percentage of the tests that were positive, but now so many folks are doing at-home antigen testing that the case counts that we get, the PCR tests that folks go and get at a testing center at the hospital, not quite as accurate. So we're really focusing more on the severity of illness, which is defined by hospitalizations and the number of deaths in the city. And fortunately in Brockton, we measured wastewater, the amount of COVID RNA in wastewater. So that gives us a much more accurate idea of how much COVID is actually in the community. So if we look at the numbers, this is what the numbers tell us. Each blue bar is a PCR test that was obtained on this day. This is the last 4 months. The black line kind of tells us that we've been hovering between 15 and 20 cases per day in the city. But if we put it all in perspective and look at the entire length of the pandemic, this is from March 14th of 2020, the very first case. We've been through a few different COVID variants. Currently, the BA.5 variant is the one that's accounting for most of the cases in Brockton. But you can see things have leveled off. I don't trust this number here. I think it's much higher just because So many folks are doing home antigen testing and not reporting that to anyone. If you want to know who's had COVID in Brockton, it's everyone, all age groups across the board. Everyone has been affected. This is, as I mentioned, we measure percent of cases that are positive. We had been kind of hovering in the 6 or 7% range. We've ticked up to 8%. Next week, it looks like we're going to go up even a little bit higher. We'd like to be under 2%. So COVID still in the community based on the test counts. The thing that's a little bit worrisome is the fact that nearly 10% of our hospital beds between the two hospitals in Brockton right now are occupied by COVID patients. We're not where we were at the end of March when nobody was in the hospital. Really continue to creep up so that 1 in 10 hospital beds right now in the city is occupied by COVID patient. Under 5% is the target. Over 10%, it means the hospitals are really feeling the burden of COVID again. The death count, and I think this is thanks to the fact that so many people have immunity, either acquired immunity from vaccinations or from having COVID in the past, that our death count remains relatively low. We did have 1 new death reported this week. And this is what the age group looks like of folks that have died from COVID. You can see really it's the death toll is really affecting 60 and over who are dying from this illness. And this is why it's so important, especially for the older population, to get vaccinated. If we look at the case count, this on the left side, this is who's gotten COVID, and on the right-hand side, who's died from COVID. You can see it's really remarkable that the disease is really deadly. Nearly 25% of anyone over age 80 who gets COVID dies, whereas really about 0.1% of folks under age 50 die from COVID. It is really a deadly disease for the older population. As I mentioned, in Brockton, we are one of the several communities in the Commonwealth that does wastewater sampling. Not all towns do it, not all places do it, so we're lucky to be able to have that available to us. And we can kind of get an idea of where COVID is in the community just by looking at these wastewater samples. This peak right here is the Omicron peak that happened at the very beginning of January of this year. Lots and lots of COVID. Now it's still out there, kind of looks like a bit of a scatter diagram here, but this tells me that COVID is still circulating in the community. I'm not going to go over this. It's a mess, a lot of data, but just to let you know, you can look at it and take your time, because this is the weekly dashboard that the city publishes every week on Friday, except today because I'm traveling tomorrow. So it'll be on Thursday today, but every week we publish it. You can see it tells you how many folks are in the hospital, how many folks in the city right now actually have COVID. And I take the data. This was data that was released at 5 p.m. tonight, so it's pretty up to date of how COVID looks in the towns that are surrounding Brockton. I did want to just a moment touch on the new vaccine. So for those of you who were vaccinated and got boosters way back when, don't forget the new booster that came out on Labor Day is an updated booster. It is being re-engineered and specifically targeted against the BA4 and BA5 variant. And because we do wastewater sampling in Brockton, we know that right now, this week, 95% of all the COVID circulating in Brockton is BA5. So we are very fortunate that there is this new booster that specifically targets the circulating variant that is right now in the city. Now is the time to get the new booster to protect you and going into the fall and winter and holiday season to protect you against COVID. And new this week, that same booster has now been recommended for age 5 and up. Before you had to be 12 and up, but now anyone over the age of 5 can get this new booster that will protect you against the circulating variant. We have clinics in Brockton every Tuesday and Saturday, plus lots more clinics, and virtually every retail pharmacy offers some kind of clinic in the new booster. And I just want to also mention that there is a medication out there. Paxlovid is a oral antiviral medication that targets COVID, specifically designed for folks with COVID, mild to moderate illness who have some kind of underlying condition. The idea is, though, you want to take it right away as soon as you test positive, and the Massachusetts Department of Public Health offers a free telehealth service to be able to take that medication. And just in case you want to start your early planning for Thanksgiving and you want to be indoors and safe with your family members, get your booster now so that you'll have immunity come November. And if you're going to get together with people, we've got lots of COVID tests that are out there. Do a home COVID test that morning. Ask everyone to do it, and stay home if you have symptoms, and you'll be able to enjoy Thanksgiving the following year. So just one more thing. The President of the United States has said that the pandemic is over. Most of the folks who are taking care of COVID patients would disagree. The governor of the Commonwealth about an hour ago released this mask mandate. So I'm not going to go over all the details, but just reiterating that masks are in fact required in certain healthcare settings. And if you don't believe that, the pandemic is over, just ask the 500,000 new cases that were identified around the world in the last 24 hours. There is plenty of COVID to go around right now. So, if you ask, the person I trust most to ask if the pandemic is over is Rocky, and Rocky says it ain't over till it's over. So Rocky says pandemic is not over, and I believe him. So that is the update on where we stand with the COVID in the city.
Thank you so much, Dr. Herman. Thank you so much. Ladies and gentlemen, and in order to put on a program like this, we need the help of so many people. And I want to give thanks to those people who have shared this information with their networks via social network. And I especially want to thank the church leaders who have volunteered to share the information about this program being held this evening with their congregations. Reverend Houston Creighton of Lincoln Church has been very, very helpful. Apostle Edward Campbell of New Jerusalem Tabernacle, Reverend Ortiz Vandross, Reverend Cedric Rucker. Reverend Ortiz Vandross is the pastor of Full Gospel Tabernacle, and Reverend Cedric Rucker is the pastor of Mount Moriah Baptist Church. Also, at Messiah Baptist Church, Miss Sharon Molden has been very, very helpful, along with Reverend Marlene Gill of the United Interfaith Action. And I'd like to thank also the many friends who have shared the information of this flyer and the link throughout their network. I would be remiss also in thanking other committee members. Glenn Cornelius of the Good Samaritan Medical Center has been very, very helpful. Janet Trask, who's the chair of the Health Committee at the NAACP. Leona Martin, who's the chair of the Education Committee at the NAACP and also doubles as a member of the Health Committee. And of course, our president, Phyllis Ellis. Without the hard work of all these people, in addition to the expert staff at AdMeTech, we are able to put this program on. Without their help, it could not happen. At this time, if Representative Jerry Cassidy has joined us, I'd like him to say a few words. Is Representative Cassidy on the program? It is, unfortunately, for those families that are affected by a member in their family having prostate cancer, an arduous task to be caregivers and the emotional support that they need and give to their family member who is affected by prostate cancer is so important to the patient's goodwill and future health. We have in past forums had individuals, prostate cancer survivors, who have given testimony, and they have been a tremendous advantage and we're thankful to those men who have given their individual testimonies. This evening, we're going to hear from the Roberts family. But first, I want to introduce to you Miss Deborah Roberts, who has been mentioned by Senator Walter Timothy, because she serves a very, very important role in the town of Stoughton. Deborah Roberts is the first Black person, Black woman, to be elected to the select board in Stoughton. She's a longtime resident and very active in Stoughton. She is the first Black Select Board chairperson. She is the founder or co-founder of the Stoughton Diversity and Inclusion Organization. Deborah is also a co-founder of the Stoughton Equal Opportunity Commission, which is an advisory commission to the advisory board of the Select Board. Deborah Roberts is a friend and a very, very significant person to the well-being of all of her constituents in the town of Stoughton. And I'd like to introduce to you Ms. Deborah Roberts at this time to share with us her family situation. Thank you. Deborah, are you there?
Thank you very much. Can you hear me? Thank you so very much, Steve Bernard. He's a longtime friend and colleague of mine and the family. And I also want to mention that I'm an advocate and supporter of President Phyllis Ellis of the NAACP and of AdMeTech. And I tell you honestly, if I hadn't had this network and attended their meetings early on, I would have been really devastated. But at least I had a network and I had information. Because when you talk about prostate cancer awareness, it impacts females in the family as well as that male that was diagnosed. 1 in 7 males will be diagnosed with prostate cancer. Those of African descent are 2.5 times more likely to die of prostate cancer. Charles Roberts was the one. He was the 1 in 7. And I often think, well, who's going to be the next one? You know, I have male children who are approaching the age of 40 because they asked us to start having screening when you turn 40, but they need to know about this earlier than age 40 so they can start talking to their doctors about this devastating disease. Now, I'm not going to sugarcoat this at all. It's hard, it's sad, it impacts the whole family, because you have to understand to listen to your partner, listen to that person that is going through treatment. Also, you need someone to talk to. What should you expect? What's coming next? You know, sometimes you're crying at night because you just don't have the answer. But when you reach out to like AdMeTech, organizations such as that, and NAACP, you find that you have a network. Later, right after I talk, you'll hear from Charles Roberts. He'll tell you about his struggles, his challenges, mind, body, spirit. And then you'll hear from Erin Roberts, how she supported her father during this whole process. Yes, I'm the select person for the town of Stoughton. Stoughton has a population of about 30,000 residents, a large population or a significant population of people of color. So I want to encourage them, like I encourage my family, to get tested, get screened, be informed. Once again, Chuck is a survivor, and I'll turn it over to Chuck and to share some more information. We're just being real with this. Thank you.
Good evening. They call me Chuck, but I'm Charles Roberts Jr. I'm also a retired police officer. My detection of prostate cancer was detected just in my annual physical. My blood work was taken, and my doctor told me that my PSA was at 13.7, and that was in November of 2020. So in December of 2021, I was referred to a urologist for testing. And at that time, I was diagnosed with stage 2 prostate cancer, and also that my prostate was enlarged. The only symptom that I experienced at the time was getting up and going to the bathroom late at night a lot of times. That has decreased a lot. since I was originally having those problems. I started treatment in January of 2021. It was a 2-year process. Prior to any medical treatment I was taking, I was given a solution, a CBD solution that was designed to reduce the size of my prostate. In 30 days, my prostate was reduced. In January 2021, I started chemo. I started a 3-phase treatment. The first one was chemotherapy. The second one was hormone therapy. And the third one was radiation. Once I started the chemotherapy in February, my prostate was physically checked again. PSA was down to 7.6. So in the last 2 years, I just finished the actual medical treatment, which was the hormone therapy, this past August. And I'm happy to say that my PSA is so low that you can barely detect it. It's down close to 0. So it's working. I'm on my way to recovery. Some of the side effects that I've had were heat flashes, extreme fatigue, and sweating, which is what I'm still going through now. So it's going to take some time for all that treatment that I had in the past 2 years to leave my system. But I am on the way to recovery. And the one thing I would like to say to the gentleman out there is that, hey, don't ignore any symptoms. If you don't have any symptoms, get an annual physical where they can detect things like this. Because if they catch it early, you're probably going to be all right. I don't know if there were any questions or anything that anybody might have that I can answer. If there's no questions or anything, I'd like to introduce the next speaker will be Erin Roberts.
Hi, how is everyone? My name is Erin Roberts. I am the CEO and one of the co-founders of Effulgence. Here at Effulgence, we sell organic dietary supplements, CBD, and accessories, and we also do our own cultivation and manufacturing. So even for me being in this industry of holistic medicine or alternative medicine, it was definitely a shock knowing that my father was diagnosed, but I still knew that I had to, help him attack this as quickly as possible. But that being said, my partner and I, who is my uncle, Ernest B. Collins, who actually healed himself from a broken neck and prostate cancer by ingesting cannabis. We both actually assisted my father in taking his dosages. And like he said, we got his PSA from a 13.7 down to a 7. So that was very rewarding for us with our family. So with that being said, here at Effulgence, we do believe in taking the preventative methods and knowing the proper knowledge to prevent future diseases such as prostate cancer. This is something that is serious. It isn't something that, you should overlook. Definitely changing your lifestyle, eating more healthier, eating more green leaves in your diet can definitely also help. But also with the help of doctors, with their knowledge, with their technology, equipment, things like that can also assist you in, continuing your life and enjoying your life. So with that being said, I would definitely pass this on to Phyllis Ellis, and thank you so much for having me.
Thank you, Roberts family. We appreciate you coming on to give us your stories. I hope you'll come back again when we have our next event, probably in 2023, but we really appreciate you coming on tonight. At this time, it is my pleasure to introduce Dr. Sean Wason. He joins our other distinguished doctors who have been with us from the beginning. Dr. Wason is an assistant professor of surgery and urologist at Boston Medical Center and Boston University Medical School. Dr. Wason will review advances in screening and diagnosis of prostate cancer. Dr. Wason, are you ready?
I am. Thank you so much. And I really appreciate the invite, especially such distinguished panel of guests. Tonight, I have no disclosures for my talk other than, prostate cancer does run in my family. My grandfather from Barbados had metastatic prostate cancer. And so I was aware of the disease early, and I'm not sure if this is the reason why I'm on the path now. But tonight I want to review certain things about prostate cancer, go over some of the screening methods. What are the goals of screening? Who do we screen? When do we screen? And why? And, these are my 2 boys, 5 and 8. And this is the reason why I'll be screened next year for prostate cancer. I'll be 45. And then how do we make the diagnosis? what type of imaging do we use, and then what are some of the roles of the biomarkers. And so we all know prostate is a gland that kind of sits tucked in between the bladder and the rectum. Historically, it measures about 30 grams, but I have seen prostates, from this area up to about 300 grams. It's part of the urethral channel, and its function is reproductive, and it contributes to semen. And so we all know, 1 in 6, 1 in 8 men will be diagnosed with prostate cancer in their lifetime. And really the goals of prostate cancer screening are to maximize the detection of the intermediate and high-grade cancers, to really minimize the detection of non-life-threatening cancers, and then really decrease the unneeded biopsies and treatment of men. And so we're fortunate in that we have the American Urologic Association every year. They come up with these new guidelines. This was the guideline for early detection of prostate cancer in 2018. And really, when we say early detection, it really means screenings. And this implies detection of disease at an early pre-symptomatic stage when men would really have no other reason to seek medical care. And so what does the panel recommend? So it recommends against PSA screening in men under the age of 40. So in this age group, you don't have to worry. There's a low prevalence of clinically detectable prostate cancer. In men that are in between the ages of 55 and 69, you want to proceed with what we call shared decision making. So a decision made between the care provider and the patient. And I think that this particular age group really benefits the most from screening for prostate cancer. And the panel doesn't routinely recommend PSA screening in men over the age of 70. Doesn't mean that you can't get a PSA done if you're healthy and over 70, but we don't typically recommend screening in asymptomatic men. So how do we find prostate cancer? PSA, it's a blood test, digital rectal exam, quick exam. And it's done best in combination. So we combine PSA, digital rectal exam. For the most part, this is done annually, but in order to make the diagnosis, you really need a prostate biopsy. So what exactly is prostate-specific antigen, PSA? It's a protein in semen which liquefies the ejaculate. It circulates in the blood of all men with intact prostates, meaning that if you had your prostate removed, the PSA should be undetectable or zero. The good thing is that it's only made by the prostate. However, it can be elevated in certain conditions such as inflammation, infection, trauma. But it really is like the first early biomarker that we have, and it's used in all phases of treatment. So screening, diagnosis, after treatment, it's used in advanced disease and metastatic disease. So from a urologist perspective, most agree that mass screening is in the past. We do know that PSA has several limitations. We advocate for shared decision making. And then there are high-risk patients that really should be considered for screening. So these are patients that have a strong family history of prostate cancer, and not only prostate cancer, but breast, ovarian, African-American men. Age and comorbidities will often dictate the action, and then who gets screened is dictated by the primary care doctors, and then we're the ones that often dictate who gets biopsied. And so in terms of early detection, if the PSA is less than 1, this is great, especially if they have a normal digital rectal exam. You can expand the intervals between time that you get a PSA. If the PSA is between 1 and 3, you can repeat the testing in about 1 to 2 years. The patients that we want to see in the urologist's office are anyone over the age of 50 with a PSA greater than 3, suspicious digital rectal exam. And then these are the patients that we really want to put into 2 categories. Do we have a high suspicion of prostate cancer or low suspicion? And there's several tests that we can do in those with a low suspicion to really rule out the patients that don't really have a risk of prostate cancer. But we can use things like MRI, biomarkers in these group of patients to really figure out who needs a prostate biopsy. So any men that comes in to see me, they can come in with lower urinary tract symptoms, elevated PSA. We'll typically do a transabdominal ultrasound. This is a non-invasive test. We get immediately the size of the prostate, the anatomy, is there any other pathology located into the bladder. That will combine with PSA and a digital rectal exam. If there's concern for prostate cancer, then there's really 2 types of biopsies that we do, transperineal versus transrectal. Historically, the transrectal ultrasound is quick, it's easy to perform, but we've realized that there's increased risk of bacterial contamination. And so your urologist may offer a transperineal route, which can target anterior lesions in the prostate and really virtually eliminates any kind of infectious complications. So I think urologists are moving towards the transperineal approach. And there's a transrectal probe. It's a great way of imaging the prostate and reaching it. There's a different type of ultrasound. This is a high frequency ultrasound. Fortunate to be part of a large urology group practice in Virginia Beach. And we were one of the early centers using this particular high intensity ultrasound to image the prostate. And this one particular group, ExactView, came up with a scoring system. And so under real time, using just ultrasound, you can get a pretty good determination of areas within the prostate that you want to target with biopsy. And so it has a higher frequency than the traditional ultrasound that's being used. We typically take 12 cores, and these are done in the peripheral zone of the prostate. And this will tell us the grade, how aggressive the prostate cancer. Gleason 6 is least aggressive, 10 is more aggressive. What is the volume? Where's the location? And we've come up with this new terminology just to make it easier for patients. Grade group 1, low risk, grade group 5, high risk. And really, this particular scoring system is based on the gland. We're using multiparametric MRI more and more common in the pre and the post biopsy phase. A lot of insurances will not pay for the MRI before a biopsy. If you're lucky enough to get one, I think that this is the way to go. And really what it's a great way of determining suspicious areas within the prostate. And you can also evaluate the local extent of disease, such as seminal vesicle invasion, extracapsular extension, or lymphadenopathy. And then we have this PIRAD scoring system, which is called the Prostate Imaging Scoring and Data Systems. And what we're really concerned is the PIRAD's 4 and 5 lesions. And so the radiologist is able to let us know, is there any areas within the prostate that we need to target? If there is, then what we can do is we can fuse using computer-aided software, the MRI to the ultrasound, and we can essentially hit the particular lesion that we're concerned about. So we know that prostate cancer is a wide spectrum of disease. This is a National Comprehensive Cancer Network. We divide patients into very low, intermediate, high, and very high risk disease. Patients that have very low and low risk disease, we tend to steer more towards active surveillance. So we'll not immediately treat you, but we'll watch you very closely. For patients that are intermediate, high, and very high risk disease, these are the patients that we really want to treat up front. We're using biomarkers, and some of these are blood tests. Some of these use tissue from the actual biopsy specimen. There's a variety of molecular biomarkers available for risk stratification. And this is for patients with suspected or known prostate cancer. And they can really be used in all aspects of patient care in the pre-biopsy phase, prior to rebiopsy, and also post-treatment. We don't routinely use these for all patients, but it's best used in combination to risk stratify patients. And their use is supported in a variety of clinical guidelines. This is just one that we typically use here at Boston Medical Center called Oncotype DX. And the tissue that's taken out in patients with low risk disease can be sent to this company to looking for aggressive genes, and they'll give us a score based on the patient's likelihood of prostate cancer death and metastasis and adverse pathology. The traditional imaging that we use after a positive biopsy are CT scan, which is cross-sectional imaging, and bone scan looking for metastatic disease. We still use these, fairly routinely in patients with high PSA, aggressive prostate cancer. But I would say that the new kid on the block is the prostate membrane specific antigen. This is a PET CT scan. So it's really a functional study. And so you use some radio pharmaceutical agents and you bind them to PSMA, and this really looks for prostate cancer outside of the prostate. So if you have a high-risk patient that you're concerned about disease outside of the prostate, this is the go-to test to get. It's also used in patients who've been treated for prostate cancer and now they have a rising PSA and you're concerned that they have disease. And so you get these phenomenal pictures where it really highlights areas within the prostate and outside of the prostate that you want to target for prostate cancer. So in summary, I would say that prostate cancer is common. Its aggressiveness is quite variable among men. Earlier detection, like mentioned several times, is favorable. We really want to maximize detection of intermediate and high-grade cancers and really minimize detection of non-life-threatening cancers. And we're using imaging and genomics to improve risk stratification in our men with prostate cancer. And this has really allowed urologists and patients to be a little bit more comfortable with active surveillance and treat the men that really need to be treated. So I appreciate the time. Thank you.
Thank you, Dr. Wasson. Is there any way you can share that presentation with us so we can share it with other
Absolutely.
people or no?
Absolutely. No
Oh,
problem.
great. Thank you.
Okay.
Very informative. Next up, we have Dr. Ryan Frankel. He's been with us from the beginning. He is a urologist and prostate cancer expert at the Greater Boston Urology at Northeastern and Good Samaritan Medical Center here in Brockton. Dr. Frankel will be providing us clinical perspective on the advances in prostate cancer treatment. Dr. Frankel, it's your turn.
Thank you, Phyllis. I appreciate the invitation. I appreciate the invitation to be able to speak to everyone today. Dr. Stern reached out to me a number of years ago, and I believe this is the 5th year I've had the opportunity to speak to all of you. And it's something I really enjoy doing. I think the reason that I was invited initially is, I work in Brockton. So a lot of the patients that will be found to have an elevated PSA will end up in my office seeing myself or one of the other 4 urologists that work in Brockton. So, hopefully I'll have a chance to see some of you in my office at some point, or perhaps some of the people that I'm speaking with today have been in my office. And it is really something that we need to focus on. There is a higher risk of death in African-American men, as has been established. I'm going to be speaking to you about advances in treatment of prostate cancer. Before I get into that, one of the issues that I've really tried to focus on in these talks in every year in the past is about you as a man, or if you're a woman on this call, your significant other or your son or your father, to be your own advocate as it relates to your healthcare. Prostate cancer and prostate cancer screening was very common, was sort of really a standard part of the algorithm at any primary care. History and physical was what was expected. And then there was a time where it became less popular, less common. There were some statements to suggest that PSA screening was not a good idea. And, there was a time where really patients needed to advocate for themselves. I think the pendulum has swung a little bit back in favor of PSA testing, but I would certainly encourage each and every one of you that's on this call that if you're in that sort of age group between 45, 50, and 75, in that age group, that you speak to your doctor about getting screened. Find out why, if your doctor does not encourage, find out why, and try to advocate on your own behalf, because really you're the person that's most impacted by that. And I would, again, try to look at yourself as an advocate on your behalf. In regards to changes in treatment, really is basically when we talk about treatment for prostate cancer, and Dr. Wasson, showed that slide where there's different phases of prostate cancer and where the PSA comes in. But generally, when we talk about prostate cancer treatment, we tend to sort of think of it in 2 categories. The first is localized treatment. In other words, when you have prostate cancer that's localized to the prostate itself, it hasn't left the prostate, which is kind of where we want it to be, so we can treat it there. We call localized treatment. And by and large, in the localized treatment area, there really hasn't been that many changes over the past 5 to 10 years. Certainly, surgery, prostatectomy now almost exclusively is done robotically. So with 5 or 6 small incisions rather than one large incision, we remove the prostate for someone that has prostate cancer. Also, radiation is a very common form of treatment. There are some other treatments that are available, but by and large, the localized treatment paradigm has not changed that much. What's really changed, though, is in what we call the systemic therapy, where the prostate cancer is no longer in the prostate itself, but rather it is spread outside to other parts of the body. Sometimes someone had treatment for prostate cancer, either surgery or radiation, and basically afterwards, as we follow patients for prostate cancer, their PSA will rise, and that would suggest that either there's a recurrence locally within the prostate or some other part of the body, or that we may identify other parts of the body that are involved through testing like Dr. Wason was talking about, the PSMA. And so fortunately, the world of treatment of prostate cancer after you've had recurrences, when I trained 15 years ago, we really didn't have many choices at all. It was basically hormonal therapy. There's different hormones that we would use hormone blockers really, to try to lower a man's testosterone to a lower level, close to zero, and prostate cancer responds to that. And secondarily, for patients after we had lowered the testosterone and still the prostate cancer was growing, there was chemotherapy that was available. But over the past 10 to 15 years, the field has changed profoundly. And now, there's a lot of other choices for how we treat patients for systemic therapy when the cancer is outside of the prostate. And that's typically when the cancer really wreaks havoc. That's when you develop bone pain. You can block your kidneys, really make urinating next to impossible. And so these are areas that we really are fortunate to have some real new modalities to treat. Nowadays, in addition to the chemotherapy, which is sort of the last line, there's a number of pills that can be used. Now, I think 5 what we call hormone modulators on the market that are pills that you could take after you're developing worsening prostate cancer despite the early hormones. In addition to that, there's immunotherapy, where you can take blood out of a patient's body, someone who has prostate cancer, and sort of like a vaccine of sorts, you modulate the blood and bring it back into the patient, and that can fight the prostate. Also, since prostate cancer tends to go to the bones, it's a very commonly spreads to the bones, there's treatments that are out there to target the bones and have shown real benefit, real survival benefit. People are living longer with these treatments. All of these treatments that I've just mentioned to you, whether it's the pills, the immunotherapy, or the bone modulated therapies, all of them are tolerated much better than traditional chemotherapy. So, in the old days, patients, when they were getting chemotherapy for prostate cancer, it was tough. It was very difficult to tolerate. But now these treatments are much easier to tolerate, which is really encouraging. I'll leave you with this. It's just, again, I think the main reason for this talk today and the main goal is prostate cancer awareness. Once you get the diagnosis, you're going to be plugged into the right doctor. You're going to get lots of good advice. But it's getting in to make that diagnosis to begin with. That really is where the awareness needs to be at. And so consequently, I would encourage you to get screened, to talk to your doctor about getting screened. Be your own advocate so that we can catch it early and we don't see some of the long sequelae of prostate cancer that, again, are really the difficult aspects and difficult for us as doctors to deal with when it presents later in the disease. So that's all I have for you today, and I'll turn it back over to Phyllis. Thank you for offering me the time.
Thank you, Dr. Frankel. We really appreciate you coming on again. I think it's your 3rd time this year. We appreciate you so much.
Thank you.
Last but not least, hearing from our distinguished doctors is Dr. Faina Stern. She is the president and CEO of AdMeTech Foundation. She's also one of our best partners. We have so much enjoyed you, Faye, over the last 7.5 years. We appreciate all that you do. Tonight, she's going to be describing the newly found Prostate Cancer Equity Program. Dr. Stern.
Phyllis, thank you so much. And I cannot begin to express my gratitude to Brockton NACP, to Good Samaritan Medical Center, to everyone here for attending the survey outside of working hours on Thursday evening and being incredibly effective partners for well over 7 years, I think. I will address the details in my presentation, but Dr. Sean Wason, when he mentioned that what set him on the path of prostate cancer subspecialization in prostate cancer and focus on prostate cancer was his father's metastatic prostate cancer. My father, the same thing with me. I would never forget the moment when I learned that my father was diagnosed with prostate cancer. I was always very close to my father. All my medical theoretical knowledge went right out the window, and the only thing for several hours I could think about, my dad has cancer. But this fear, he ended up having early prostate cancer disease. He ended up having the kind of disease that he did not even have to have treatment for. But that fear, that stress, that worry about my father prompted me to shift the focus of my career towards prostate cancer. So whatever I've been doing ever since is essentially about prostate cancer. I changed my career from breast cancer to prostate cancer when I was still at the National Cancer Institute heading diagnostic imaging. Without much further ado, I would like to ask my staff to play the video. We prepared video because we had so many problems with PowerPoint presentations at different events. So we started resorting to pre-recorded videos for virtual events. So if you can please show my video about prostate cancer equity program. Dr. Wason and Dr. Frankel described extremely exciting novel advances that appeared over the last several years in screening, the diagnosis and treatment of prostate cancer. We started struggling with the question how to bring these advances, how to make them available to everyone, how not to leave men behind, particularly vulnerable men. I will describe this new prostate cancer equity program in my talk, and Dr. Ryan Frankel has been a part of this program from the beginning, and we certainly are dead set to get Dr. Wason as one of our clinical providers. So my video, please. Hello. My name is Faina Stern. I'm a physician to Brockton NACP and Good Samaritan Medical Center for their long-term partnership, including this event. Also, I'd like to thank AdMeTech staff, Thomas Satam, Emma Coyard, and Trisha Kinney in particular. AdMeTech Foundation provides leadership for the groundbreaking programs in prostate cancer at the state, national, and international levels. Our programs have been transforming patient care for everyone and reducing health disparities in Black, including Hispanic men. Dr. Wason and Frankel addressed recent and rapid advances in screening, diagnosis, and treatment. The main goal of my talk is to describe our new prostate cancer equity program, launched recently to bring these advances in patient care to every man in Massachusetts and eliminate health disparities. This event and prostate cancer equity program is an integral part of the AdMeTech's ongoing statewide program in prostate cancer that created a Massachusetts model of national leadership in public awareness, medical education, and research. We are grateful to Representative Cassidy, Senator Brady and Chimilty, and other members of the Plymouth County delegation to the State House who made this program possible. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. This program was initiated since 2009 in collaboration with multiple organizations and has three components: public awareness, medical education, and research. For public awareness and education, we had reached well over 36,000 men since January 2020. While we are dealing with COVID pandemic, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable concern of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits, telehealth, ongoing in-person care, doctor's appointments and testing, and medical procedures such as biopsies and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men in our country. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only about 28% of men remain alive during the same time. In prostate cancer, screening with blood tests called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as Black heritage, family history of prostate cancer, particularly in a brother or father, and increasing age, 50 and older. You can ensure early detection. During annual visit, ask your doctor about PSA blood test and digital rectal exam. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors I just mentioned. Before screening, it is important to avoid exercise or sex, which may impact your testing results for 1 week. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert for further evaluation. For public awareness and education, our messaging centered on the importance of screening and early detection, clinical for saving lives. In 2015, jointly with Brockton NACP and Good Samaritan Medical Center, we focused on Plymouth County, which led the state in Black men's mortality, together with Suffolk County. As of 2021, Black men's mortality in Suffolk County is still the highest in our state and about twice as high compared to Plymouth County, where we had undertaken extensive awareness campaign. In 2015, as this blue bar shows, Black men were more than 2 times more likely to die compared to white men in Plymouth County. These disparities in prostate cancer mortality in Plymouth County were higher than state average. In Plymouth County, this is state average disparities in prostate cancer mortality. By 2021, Black men are only 1.2 times more likely to die compared to white men in Plymouth County, with the difference reaching near parity. This reflects over 55% reduction in disparities in prostate cancer between 2015 and 2021. Currently, disparities in Plymouth County are much lower than state average disparities, as shown in the red bars. During the same time, between 2015 and 2021, there was no reduction in disparities at the state level. The centerpiece of our medical education is AdMeTech's annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer. The latest 6th annual conference took place this year between September 22nd and 24th. Our summit brings together the key international experts representing every clinical expertise to review the best emerging clinical practices. This educational event showed rapid advances in patient care. In screening, our summit supports clinical guidelines for early detection recommended by the National Comprehensive Cancer Network, consisting of over 28 cancer hospitals and their leading experts. As mentioned, high-risk men, including men with a Black heritage or family history of prostate cancer, are recommended to start screening at the age of 40. Average risk men should start PSA screening at the age of 45. This first or baseline PSA result in younger men has emerged as one of the most important indicators for developing lethal prostate cancer long-term over 10 years. In diagnostics, we have seen emergence of very accurate non-invasive tools such as blood, urine, and saliva analysis for molecular and genetic markers, and advanced imaging, including ultrasound, MRI, and molecular imaging. These non-invasive diagnostics, highlighting the importance of PSA screening, shifted past concerns about screening for prostate cancer into a dustbin of history. For example, these diagnostics can determine which individual man has an increased risk of life-threatening, rapidly progressing prostate cancer, improve early detection, critical for saving lives, reduce unnecessary procedures such as biopsy and treatment, and optimize selection of personalized care for each man, including careful observation or active surveillance, minimally invasive interventions, or immediate radical treatment. High-risk individuals, including Black men, carry higher risk of both mortality, dying of prostate cancer, and unnecessary procedures. Consequently, it is critical for them to have access to precision diagnostics that determine for each individual man if he should or should not have invasive biopsy or treatment, and what options in clinical care are best for him. Unfortunately, in Massachusetts, Black men are less likely to have precision diagnostics, such as advanced imaging, MRI, or molecular imaging, or genetic testing, or undergo life-saving treatment compared to white men. Prior to undergoing invasive biopsy or treatment, it is important for each man to discuss with his doctor if any testing is available to determine if these procedures are actually needed, and if yes, what kind of options would work best for him. Based on the evidence coming from military medicine, from veteran administration, our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Program in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care. Our priority focus, again, is on Brockton and Plymouth County. Supporting organizations include Latino Health Insurance Program and NACP, New England Area Conference, with their multiple branches located across the state, including Brockton. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today. This program helps men to find an expert for the initial or a second opinion, in-person or virtual visits. Any Massachusetts man age 40 and older can take part in this program. Our priority focus is on Black, Hispanic, and Latino men who are at higher risk of prostate cancer, delayed diagnosis, poor quality care, and death. Based on our experience in Plymouth County, we believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer to informing men about all available options before and after screening, biopsy, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined VIP-style process of patient referral and care, reflecting how a physician like me takes care of my family and friends. This process consists of 3 components. 1, AdMeTech Foundation's coordinator collects basic information and matches individual patients' need with the appropriate state's experts. A clinical organization designates a patient navigator who works with multiple schedulers to expedite a medical visit. If an expert recommends any next steps, for example, additional testing or treatment, AdMeTech's coordinator and patient navigator work with men on the appropriate follow-up. To ensure successful implementation of this program, AdMeTech has created a network of leading state experts committed to eliminating health disparities, develop an effective process for patient care and follow-up, as mentioned, recruited community coordinators in high-risk areas who mobilized a network of over 100 program ambassadors, community, organization, and church leaders, held multiple focus groups to develop program materials. Our current goal is to identify and mobilize appropriate organizations and individuals so that men, their primary doctors and caregivers have access to this program. Trisha Keeney, a member of the AdMeTech Foundation staff, serves as a statewide coordinator for the Prostate Cancer Equity Program. If you have any questions or need assistance, please contact Trisha by phone, 617-523-3535, or by email, coordinator@admetechfoundation.org. Thank you for your attention. I would like to introduce at this point a very good friend and a person, Victor McCann, who has been through our prostate cancer equity program before we called it prostate cancer equity program about 10, 11 years ago. Victor, do you want to share your experience, what it was like to come to AdMeTech, to be referred by AdMeTech to leading physicians, etc.?
Yes, ma'am, I do. Good evening, everyone. Again, my name is Victor McCann, and as Dr. Stern has provided, I was one of the people who in 2013 was diagnosed with a high PSA level. I went to a urologist and he immediately wanted to do a biopsy. And I kind of freaked out because I didn't know what that really meant, what it entailed. And I wanted to find out more information. And I really was feeling lost. And I'm a professional person. I work as a software engineer for a leading aerospace company. And someone said, well, you need to talk to Dr. Stern. I talked to Dr. Stern, and as she said before, it was called the Prostate Cancer Equity Program. She asked me several questions and helped me to find the appropriate health care so that I could get help. So I just wanted to let you know that since I was with Dr. Stern, she asked me if I would be willing to be part of a clinical trial. And I was part of a clinical trial down in Bethesda, Maryland at the National Institutes of Health. And I was on active surveillance for about 7 years. And just recently, through collaboration with my doctor, we decided to have my prostate removed. I've been okay. I just would like to answer some questions. One of the questions that was posed to me was, did I feel alone during the process? All through the process, I knew that I could reach out to Dr. Stern and her staff, and they were very helpful in guiding me and helping me along the process. And the quality of care that I received at the NIH was very good. And again, that's National Institutes of Health. But as you know, we have very good health care here in the Commonwealth of Massachusetts as well. And I was asked as a final question, would I recommend the prostate cancer equity program to other individuals? And to that, I respond with a resounding yes. So if you have any questions of me, you can ask me and I will share with you what I know. And I'd like to return to Dr. Stern. Thank you.
Thank you so much, Victor. And I want to point out, Dr. Sean Wason had made a very strong case for MRI. Our organization led development of MRI, among other diagnostic tools. And since 1998, precision MRI and PIRATS, everything that Dr. Wason described. And at that time, NCI conducted the best clinical trial, to my knowledge, in MRI, because MRI was experimental. That's why right now MRI is practically a standard clinical tool, but at that time it was limited in its availability. And the first thing I told Victor, not to have blind biopsy, to have MRI, and that's how he ended up in clinical trial in NCI that provides completely free care to every citizen in this country, from screening to diagnosis to treatment. At this point, I think we have a question from Reverend Creighton. May I ask what your question is? Sorry, we made you wait. I think, Reverend Creighton, you're muted. Do we have any other questions from, I don't see any questions on Q&A or chat. Do we have any questions from Facebook? We do not. Okay. And Reverend Creighton wants to ask a question, but we cannot hear him. Phyllis, we are getting close to the end of the event, and I would like to turn it over to you.
All right. Thank you, Dr. Stern. And thank you all for joining us this evening. The senators, Mayor Sullivan, all our distinguished doctors, and the Roberts family, and all who joined in with us tonight. I would like Steve to do the final goodbyes and final comments. Steve?
Thank you all for participating this evening. Phyllis has said, thank you all the doctors, the professionals, the people who made personal testimonies. All those who participated, we hope that you'll share this information. All those who did not get an opportunity to see it, we encourage you to share it. We should be on Facebook or YouTube. We thank you very much for coming out this evening, and we hope that you'll continue to join us at our next Prostate Cancer Education and Awareness Forum, which Phyllis has said should be sometime in early 2023. With that, if Dr. Stern, you have any final comments, I'll be very happy to allow you to take over.
I think,
Did Representative Cassidy ever get on?
I just wanted to say thank you to Representative Cassidy, to Senator Brady, to Senator Timothy for giving us, for trusting us with state funding and giving us an opportunity to do this work. Thank you.
Thank you to the committee. Thank you all.
Thank you all.
Until the next time, 2023, save the
Thank you very
date.
much.
Bye.
Bye now.
Thank you.